So we're going to be talking about case studies from our department. The best thing about case studies is that it's bringing actual calls that our members are running. The best way to learn is from each other. So what I want you guys to do is put yourself in the situation of these providers and think about what you would do if you were in their shoes. Now, starting off with case study number 1, you're going to be on Medic 94 dispatch to a fall. When you arrive on scene, you find the patient laying supine. Their ABCs are intact, they're learn-oriented, and they say to you they fell because their legs gave out from underneath them. Now, his primary complaint is that he can't move any extremity, obviously a big red flag. Now, if any fall patient, you want to rule out possible head trauma, you want to clear the C-spine, and then you want to evaluate for the reason why they fell to help rule out possible medical causes. As they further went through their assessment, they found that the patient recently had cervical spine surgery that left him with numbness on the right side. So that is his baseline. He has a past medical history of hypertension, and the vitals on scene are as displayed. So obviously the vitals were abnormal, which should make you want to rule out any possible medical causes of the fall. So doing a 12-lead EKG, because the patient is bradycardic and hypotensive, you want to rule out any heart blocks, you want to rule out any arrhythmias. Now his EKG was sinus bradycardia. So the next thing that you should do is, what kind of medications are you on, sir? Because if he's on medications that could possibly contribute to his heart rate being low, medications that you're thinking about are beta blockers. So if the patient is on any medication that ends with LOL at the end, those are beta blockers. So metoprolol, labetalol, atenolol. In this patient, he wasn't on any beta blockers. So the next thing that you need to be thinking about is, what kind of shock could this patient possibly be in that's causing him to be bradycardic and hypotensive? So going through all the different kinds of shock, asking questions to help rule things out will help point you in the right direction. With hypovolemic and hemorrhagic shock, it is very important to ask about any recent vomiting or diarrhea. If they have had those things, you need to ask questions about possible signs and symptoms of a GI bleed. So more specifically, is there any discoloration in those things? A 12-lead EKG will help you rule out cardiogenic shock because it will rule out any possible bradycardic heart blocks, any tachyarrhythmias, and it can rule out a STEMI. All of those things could restrict the heart's ability to be able to pump out blood to the body, causing them to be in cardiogenic shock. Anaphylactic shock is 2 or more systems with allergic reaction symptoms, causing that patient to be in shock, something that we should be familiar with. And then septic shock is also a very common shock that we can kind of help rule out by asking questions for possible underlying causes of infection. So questions about vomiting and diarrhea would be a good questions to ask. Obviously, cough, fever, chills, being around anybody that's sick are all the questions that you can possibly ask to this patient. But when you put the primary impression together, the patient's vital signs, that should lead you to only one form of shock that this patient possibly could be in. And that's neurogenic shock. Neurogenic shock is more commonly associated with cervical spine injuries, but it can be associated with thoracic spine injuries. Neurogenic shock is caused by injury to the spinal cord, either a primary or secondary injury that causes that patient to lose sympathetic tone. Without sympathetic tone, your parasympathetic system takes over, causing your blood pressure and your heart rate to tank. And your body loses the ability to regulate its temperature, which is why they normally have dry and warm skin compared to the other forms of shock where you're normally pale, cold, and clammy. So neurogenic shock is associated with T6 injuries or above. Once that occurs, you lose that sympathetic tone, which causes that vasodilation, which drops your preload, which drops your stroke volume, your cardiac output is decreased, and hypotension occurs. And instead of your heart rate increasing like in every other kind of shock, that loss of sympathetic tone restricts your body's ability to be able to increase the heart rate, leading to bradycardia, which also drops that cardiac output and contributes to that hypotension. So managing neurogenic shock is going to be important to manage your ABCs just like in any other patient. C-spine precautions and spinal precautions in general are going to be huge. Try to maintain a MAP between 85 and 90 and minimize any secondary cord injury. So primary cord injury is what initially caused the initial onset of injury, and secondary cord injury is more of what we can control and making sure we're not further causing harm. In order to maintain the blood pressure, start off with fluids and then go into vasopressors. Now, which vasopressor could depend on how low the heart rate actually is. I think Levophed is the best choice of medication that you can give this particular patient with his heart rate kind of hovering around the 60s. Now, obviously, if their heart rate's in the 30s and their blood pressure is really low, then you might need to give them a medication that helps hit those beta and those alpha receptors, and then epi might be the best choice as a vasopressor in this situation. If you need to treat the bradycardia, you could give atropine and you could pace the patient, and then steroids is a controversial treatment, not something that we would do in the pre-hospital setting with our protocols, but it's something that might be done inside the hospital. I want to pose an interesting question to you guys. How would you handle a multi-system trauma patient with neurogenic shock symptoms? Now, looking back at this patient, I think it's very clear that this patient possibly could have been a neurogenic shock just based off of their clinical presentation, their vital signs, their recent history of surgery, and the way that they felt. But if you take a patient who's been in a really bad car accident and they're bradycardic and they're hypotensive, and let's say they're unresponsive with multiple injuries, you can't get a medical history on the patient to rule out possible beta blocker causes of prescribed medications that they're taking. So you don't know their medical history. So if you jump down the rabbit hole of giving this patient an epi drip or a Levophed drip and a bunch of fluid, and they have an underlying cause of hemorrhagic shock, then you're mismanaging this patient. So what I would recommend, if you have a patient who's a multi-system trauma patient and showing signs of neurogenic shock, start off with blood products. Once 1 unit of blood product has been given, reassess your hemodynamics. If their hemodynamics have improved, great, continue to the hospital. But if you're still having this patient, their hemodynamics are still poor, I would consider giving that second unit of blood on top of combining it with a pressor. So now, just like you would with a medical patient, you're giving them fluid first and then Levophed. In a multi-system trauma patient with possible neurogenic shock symptoms, you're giving them blood, helping rule out hemorrhagic shock, and then you're combining that vasopressor behind it to help tighten up those dilated pipes. Interesting question, brings up a lot of good discussion points. Obviously, if you want to talk about it further, you can talk. We could talk about this topic in more detail. Just reach out to me. So the crew on Medic 94 treated the patient by giving them 500 ml bolus first. That didn't bring up the blood pressure. The patient continued to remain hypotensive. Heart rate remained between the 50s and 60s. So then they started a Levophed drip. They mixed it. They did 10 mic push and was followed up by a Levo drip. Systolic blood pressure improved between 130 and 200. I think initially with the Levophed drip, it kind of started off and jumped up pretty quickly, went into the 200s. They titrated it down and brought that systolic around that 130 area. So some hospital documentation or a follow-up on this patient was that he ended up having a C6 fracture. Initially, the hospital was evaluating him for possible respiratory impairment just because his fracture was right below where your phrenic nerve directly intervenes your diaphragm. So if you remember, C3 to C5 keeps your diaphragm alive. Well, he had a C6 fracture. So they were kind of worried about there being any respiratory issues, but he never showed any signs of shortness of breath. And then this was a hardware fracture from the fact that he recently had surgery and had hardware placed in his cervical spine. So when he fell, that possibly could have caused that fracture. He was ultimately discharged home. Regained function, is going to be doing outpatient therapy. So great job by the crew in managing this patient appropriately. They took him to the medical center. That way he could get the highest level of care. I think any other hospital that isn't a level 2 or level 1 would have transferred this patient out. So great job by them, great management by them. So diving into case study number 2, you're on Medic 95 and you're dispatched to a rollover with engine 92. When you arrive on scene, in the driver's seat, you find a 20-year-old male sitting upright with an open skull fracture. The Patients inside, the passenger inside the same vehicle is alert but not answering questions. Supervisor 90 is dispatched by Medic 95. They were not initially dispatched when the call first came out, so there was a delay in getting Supervisor 90 to that scene. Life Flight was also asked for a weather check when they initially made contact with the patient and saw how critical he was, but they were not flying that night due to weather. And then because there was 2 patients on scene, a second medic unit was dispatched, but because 92 was already on a call, that second medic unit was coming from 4. So you had Supervisor 90 and Medic 91 coming from District 4, and this call took pretty down south deep into 2's area near the Sanat, So it was going to take a little while for those extra units to get on scene. So the vehicle was estimated going about 60 miles per hour when they struck that median and rolled over. Patient had signs of possible ETOH. In and out of consciousness, when they were conscious, like a GCS of 13, pale, cold, and clammy. The open skull fracture was to the top of the left side of the patient's head. And they did have some bleeding coming from the airway, and there was also significant bleeding coming from the open skull fracture. The patient was extricated from the vehicle. During the time of when that patient was extricated and placed on the stretcher, they thought they may have lost pulses. They quickly moved the patient to the back of the ambulance just to kind of get a better assessment of him. Once he was moved in the back of the ambulance, he did awake. They did a very detailed head-to-toe assessment on him, looking for any other injuries. They got vital signs, initiated transport, emergency traffic to the medical center. They considered RSI, but ultimately decided not to do it just because the patient was stable and maintaining his own airway at the time. His vital signs were actually within normal ranges, systolics between the 120 and 130, heart rate in the 90s, SpO2 98%. The biggest issue they had was controlling bleeding to the head. Obviously, your head is very has a lot of vasculature, and there isn't a great way to stop the bleeding. One thing that was not used on this call was combat gauze. That was the main feedback that I gave to the crew, was maybe next time if you come across this patient, put some combat gauze in that area where the bleeding is occurring in the head, and then obviously doing your best to kind of wrap the head up to kind of create some type of pressure dressing. So if you've never seen an open skull fracture, it's pretty gnarly to say the least. You have obviously parts of your brain sticking out, you have lots of blood, and it's kind of crazy to think that a patient could still be conscious after sustaining an injury like that. Now, obviously, these aren't pictures from the actual call, but when you have a patient who has an open skull fracture, the pressure that would have normally been building up inside their head in a closed space, causing their vital signs to change, causing their mental status to change, causing swelling inside that brain, doesn't occur because the brain is allowed to release the pressure because there is an opening to the outside air. So instead of swelling in an enclosed space, it is allowed to swell outwards through the opening that has been created because of the open skull fracture. So when it comes to managing a patient inside the hospital, the whole goal is to maintain an adequate cerebral perfusion pressure. So cerebral perfusion pressure is anywhere between 70 and 90, and it's the amount of blood flow that is normally getting to the brain. Now, in order to maintain a normal cerebral perfusion pressure, you have to manage the patient's MAP, which is essentially their blood pressure, and manage their intracranial pressure. Now, obviously, these are things that we can't directly evaluate out in the field, but it is very important to kind of have an understanding of why it is the stuff that we do in the pre-hospital setting can directly impact these patients. So if you have a patient with a closed head injury and their brain is swelling in an enclosed space, your intracranial pressure is going to dramatically rise. As that swelling continues to occur, you'll start seeing changes in that patient's mental status. You'll start seeing changes in that patient's vital signs that could contribute to them going downhill, forcing you to have to intubate them to manage their airway. But as I discussed earlier, if you have a patient with an open skull fracture, their brain is allowed to swell in an area that is not in an enclosed space, helping manage their intracranial pressure, which is maybe a reason why this patient was able to maintain their airway, able to maintain a mental status, and able to maintain normal vital signs. So initially, when I was going through school, I was taught that if you have a TBI patient, to hyperventilate them. Well, now there's studies that show that hyperventilating the patient is not a good thing. The only time that you should consider hyperventilating them is if they're showing signs of herniation. So that means blown pupil on one side, posturing. That could also mean seizures as a result of the TBI. So normally you want to keep that end-tidal between that range of 35 and 45. If they are showing signs of herniation, then you want to keep the end-tidal between 30 and 35. Now, not allowing their blood pressure to drop below 90 is also going to be very key. So that means giving blood products can help prevent blood pressure dropping from dangerous levels, which will help keep brain cells alive while you're initiating rapid transport to the trauma center. Remember, we're trying to maintain adequate cerebral perfusion, so if you allow the blood pressure to get too low, that's going to limit the amount of oxygen and nutrients getting to the brain, causing ischemia. And then hypoxia obviously plays an important role as well, not allowing that SpO2 to drop below 90. If you allow one of these things to occur at least one time during your care with this patient, their mortality rate has doubled. So it's very important to avoid the 3 H's in TBI. So patient got to the hospital safely after being evaluated in the ER. He ultimately was intubated due to the fact that he needed emergency surgery. He got that emergency surgery on January 22nd. Obviously, as you can see on the right side of your screen, there were a lot of things wrong, a lot of skull fractures, but I haven't followed up since that point. But I want to commend the crew for doing a good job of managing a difficult scene, managing the patient en route to the hospital, and then taking the patient to the appropriate hospital, being the medical center. And that'd be all for the case studies for January. If you have any interesting calls that you come across and you want me to look at them and potentially present them to the department, please let me know. Otherwise, thank you for watching.